Hello everyone, my name is Clarissa and welcome to DNP Mentor. Today I'm going to share how, as a DNP in mental health, I screen and I teach others about depression. First of all, I usually start off my initial consultation with information about what clinical depression is. By the time they reach a mental health provider, it is no longer about simply the emotion of feeling down or depressed or being sad, because certainly as individuals, even without a clinical depression, we have all had those reasonable emotions that go along with the situation that we're going through. So if we were to poll individuals in our own communities, we would find that a lot of people are sad or depressed right now, and certainly it goes with the times of living in a pandemic that is affecting us daily. And the situation right now isn't improving, so it's a reasonable emotion to the situation. Now, clinical depression goes beyond that, and I'll get to that in just a moment. Keep in mind that this is how I hold a consultation with the individuals that I'm going to treat, and this is usually happens during our first meeting. I'd like to take a moment to share that 17.3 million adults in the United States have been affected with clinical depression. And this is something that is impactful because sometimes when somebody is clinically depressed, they feel like they're alone and that there's nobody that they could talk to because nobody understands. Now, 2/3 of these individuals, of the 17.3 million adults, have had episodes of severe impairment. And what this means is that they have interference with how they live their normal lives. They have disruption in work, relationships, and because this is something that is at an emotional level, it affects not only the individual living with this awful illness, but it also affects individuals that they live with and people in the community, people that they work with. Depression at its worst contributes to something horrible, which is suicide. So this is something that we all as clinical providers must understand and take the treatment of depression seriously. For individuals within the ages of 15 to 29, suicide is the second leading cause of death. This is all by the NIMH, which is the National Institute of Mental Health. And sadly, it is the 10th leading cause of death for all ages. Now, when I first meet with an individual, I share this information that I just shared with you. And then I move on to say that clinical depression is, in fact, a medical, physical illness. Now, how does it jump from being an emotional situation, having an emotion that's different, feeling down, to a medical, physical problem? So I go on to explain that the brain is an organ. And I ask them, would you agree that the brain is an organ just like the heart, the liver, the lungs? And usually they're nodding their heads, yes. And so the brain, since it's an organ, it's susceptible to areas of the brain not to do its job, just like with diabetes. And I often give this example, where if somebody has diabetes, they can't regulate their insulin correctly, and so it can't always accommodate what they're eating. So I take the time to explain this as a illness that is common. So then I will ask them something like, well, if you and I don't have diabetes, we could eat a cookie and wash it down with a Coke with lots of sugar. And as soon as this enters our body, okay, the brain will know. It picks it up. It knows it's sweet and it knows it has a lot of sugar. It knows. Just like it knows immediately if something's sweet, sour, or bitter. And so what happens, if everything works correctly, the brain will send a message to the pancreas. And the pancreas will say, okay, come on, we got to work harder. We got to generate some more insulin, activate it so that by the time all the sugar reaches the digestive tract, then at that time, a lot of this extra sugar is canceled by the extra insulin that we were able to activate. And so if people take their blood sugars an hour, 2 hours after they eat, and everything works properly, I emphasize that, if everything works properly, then everything's taken care of. So similarly in our brains, since it knows everything about us, and remember, keep in mind that things at a psychiatric level, psychological level, are unconscious. But our brain remembers every experience that we've ever had, whether when we become happy, when we become sad, it knows ahead of time when we're going through a situation. So if it recognizes that we're going into something and we're going to be down or anxious, what should happen is we should be able to activate some of these other neurochemistry that will help us to get through the situation. So if you think about sharing a common experience like an interview, there are people, certainly we all get nervous, again, reasonable emotion. And people ask me all the time, by the way, how do I know if I need treatment? And the simple answer is, if your emotion does not match your situation. So going to an interview, reasonable, yes. Having a panic attack during an interview, not reasonable. So there's a difference. And so if in our brain, in our chemistry, everything works correctly, we make it through the experience. Now, it wasn't the most comfortable and we prefer not to do it, but guess what? We make it through it. And usually we say, I can't believe I worried so much. Why did I worry so much? It went okay. And so that is an experience that will go down. I often like to also give the example of people that share experiences like a car accident. And say, for example, there are 4 individuals that will go into a situation and say they are involved in a car accident. It's a serious one. And say they almost died. Now, 4 people from that group will most likely, if say there's a group of 8, about half to 75% will be okay. Mentally will wake up every morning and want to, appreciate life, and they want to get up and smell the roses, and they want to do things, and they want to call their friends, and they want to connect with people because they almost died. Now, one person from that group, guess what? Will not want to get up from bed again because they almost died, and it was horrible, and it was traumatizing. Now, I'm not talking about PTSD. I'm talking about sort of activating depression. And so what's the difference? Now, do you think that the individual that is staying in bed, okay, and some people say, well, they're choosing. Well, we don't choose to activate insulin. Okay, who would choose that? Who would choose to want to take insulin? Who would choose to want to take medication for diabetes? Nobody. Who would choose to be down, depressed, devastated, not to want to enjoy life again? Who would choose that? Okay. But nevertheless, their brain chemistry does not help them. And so, therefore, here is the illness of depression. So I also want to convey during the first initial session is that somebody that has clinical depression isn't a choice. It isn't because they're weaker, they have poor character, or because, they want to have it. Because what's the payoff? Misery? Who would choose that again? Nobody. And so you have to teach them to look at it as a medical problem, because that's what it is. And so from there we can start, because then they can start letting go of the shame, the stigma, the guilt. Can you imagine guilt? We add on to a serious medical issue. Imagine somebody with cancer feeling guilty because they have cancer. It makes no sense. And depression should be the same. No guilt associated, because guilt belongs when we intentionally do something fraudulent or something harmful. Guilt does not belong, because in this case, the person didn't do anything to bring on the illness of depression. And so I clearly state, now, if there's nothing, and I tell them, if there's nothing that you learned from today, okay, I want you to take home that there's nothing that you did, that you didn't do, that caused you to have the illness of clinical depression. Nothing. And so a lot of the times I will get sort of like a big sigh with a big relief. And sometimes, like with many individuals, because we are individuals, it takes a little bit of time for that to settle in. And I'll bring it up as we work together. But in a nutshell, that is my introduction to treating somebody with depression. And then I go on to the assessment. So subsequent videos will go ahead and have the subsequent questions. And I get information not to pry or to write down and check in boxes. There's a reason for it. And as I cover my initial consultation with you all, I will sort of explain the rationale for the questions that are chosen. And certainly, there are standards of care, which I do cover, but I go a little bit beyond that. And I'll give you an idea of why that is done. And remember, it's important that we establish sort of a connection with our patients. because they have to trust us and they have to feel comfortable that we are knowledgeable, that we care, and that we're going to help them. Now, as I end my initial consultation is I like to give hope and not false hope. Now, just like treatment for diabetes works, treatment for hypertension works, guess what? Treatment for depression works. I see this every day in my practice. Every day. I see people one way when they come in for an evaluation. And as we move forward, it's different. And certainly by the time they're discharged, they're different. And this is something that I not only see, but they tell me. I get comments every single day. So I like to impart hope because it belongs. And sometimes with depression, we lose hope. Now, one of the other things that I think is very, very important is that we share that depression, the illness of depression, lies. How does it lie? It takes away hope. It makes us feel like maybe we don't matter, we're not important. Oh, I don't really have big problems. Look, somebody over there is really ill. And look at this and look at that. I'm not worthy. Lies. Depression lies. And emotions lie. So just because I feel one way right now, later on, something else happens and I might feel different. So we don't rely on thoughts that we have because depression lies. And I tell people, recognize it. Is it a lie? Okay, depression's lying to me. Now, I don't say suppress a thought because that doesn't work, but process it. Okay, depression. I know I have clinical depression and my depression lies. This is a lie. Just like if my neighbor was lying to me. You handle it in that way. And you learn to do this. The other thing is that I want to take the time to make sure that people are screened properly. And by screening, I don't necessarily mean diagnosis. Now, the screening is important, and I use the PHQ-9 because this is something that is used in my practice. And that's something that I'm going to review briefly with you. It's 9 questions. Now, the answers are subjective. But the number that we get at the end, I sort of put as objective data because this is something that we can compare from visit to visit. Now, think about if I asked you, how are you doing? And most people will say, oh, I'm doing okay. Okay. But if I asked, within the last 2 weeks, have you been feeling down or depressed? They might say, yeah, about half the time. So the answers for PHQ-9 are not at all, several days, more than half the time, or nearly every day. And so if they say, oh, about half the time, so that would be a 2. You've been feeling down or depressed. The second one is, are you enjoying the things you should be enjoying? No. Again, about half the time. Problems sleeping, either sleeping too much or too little. Problems with concentration. Problems with appetite, either eating too much or too little. Now, within the last 2 weeks, have you been having thoughts that you have been a failure to yourself or to your family? That's another question. And then what about, have you been told by others that your movements have been slower than usual or maybe more fidgety? Now, why is this important? And this is something that a lot of nurse practitioners that I train or that other nurses that call me is that why do we ask that? This is not a physical problem. Now we ask because there's a thing that is known as mental retardation, which is where there's sort of like a delay in how we respond to our messages from our brain. And an example that I can give you is when I was seeing patients person to person. Right now we're doing all by video or by phone. When I go into the waiting room and I would call a person and I could tell sort of the answer to this question, I would still ask it the way they would stand up and walk with me. When somebody's severely depressed, even moving is difficult. And then on the other side, you have somebody that might be very, very fidgety, very, very fidgety. And so you assess for sort of the mental retardation, and then you also assess for an increase in activity, fidgetiness, and then that goes along more with anxiety, but nevertheless, it's something that's included in the PHQ-9. Then the last question, which is number 9 on the PHQ-9, is, have you had thoughts of hurting yourself or maybe thoughts that it would be better if you weren't alive, or that you would be better off dead. This just asks the questions. A lot of times people will say yes, but they don't have a plan or an intent, so you don't have to put them on a hold. But it's just something that sort of gives us a more definitive answer as to where they are in their symptoms. And it's important. And so with a score, I say it's a 10, that would be a moderate depression. And say the score is moderate, but then the next visit it's a 14, goes all the way to 21, then I know that their symptoms are getting worse. But if the numbers are decreasing, then I know that the treatment is working. So it's a way of us to assess sort of where the symptoms are. And when I start off my assessments, my visit, initially, hello, nice to see you again. Let's go ahead and get started. I'm going to go ahead and get started with the assessment. So within the last 2 weeks, have you been feeling down or depressed or hopeless? And so that is how I start the assessment. So that will conclude this video presentation. I hope that is something that you all have learned. And I am going to start filming my second episode, which will be on behavior activation, self-care, and other things related to mental health that certainly we teach others to do. And this is something that we have to incorporate ourselves. Thank you so much for watching. I hope that you like and subscribe to my channel.